Hi, everybody. This is Dr. Elsico. Happy Sunday. Happy Super Bowl Sunday. I'm here with Dr. Riad Cachecho. Riad, thank you so much for being here.
Oh, it's my pleasure, Elsie. It's exciting to discuss this topic.
Yeah, so my name is Dr. Elsico. I'm the CEO and founder of Lead Physician. I would love to introduce to you Dr. Cachecho. This is a topic that people don't want to talk about sometimes, especially physicians. And I thought this was what he has to share is tremendous. He is a trauma surgeon out of South Shore Healthcare System in Massachusetts. He's a prior chairman of the department, prior chief of trauma of a healthcare system, as well as a Six Sigma black belt at Villanova. We're talking about disruptive behavior in the workplace, toxic behavior by physicians, what we can do to help them, how can we help organizations. First, let's start by defining what that is from a surgeon standpoint, and I think that's what makes us unique because we're talking to a trauma surgeon.
Okay, Elsie. So that's a really a good question. So before we talk about how to solve it, we need to know what we're talking about. And my favorite actually definition is the one I found on the Joint Commission website. And it's by definition it's an intimidating behavior that may compromise patient safety. Period. Okay, so any behavior that affect in a negative way patient safety is a disruptive behavior. Sometimes we like to call it unprofessional behavior to tone down the conversation. So don't look like we're confrontational with the people we're trying to solve a problem with. So any verbal outburst, any physical threat, any slamming the phone, not responding to nurses' calls, being cynical when you discuss a patient's status, they're all considered disruptive behaviors.
Why do you think that this happens more often in certain subspecialties, surgeons in particular?
Well, most of the time it's the pressure. It's the pressure to perform. It's not bragging. The surgeon in the OR, you go in, you plan an operation, and things start going in the wrong direction, and you have to make a split-second decision. So you're under pressure. Then someone does not perform as expected. Then you exhibit that behavior. Sometimes or rarely it's acceptable to sort of be upset and express that, but most of the time, it's just not expected and not accepted. My expectation is that if that happened in the operating room, that the surgeon eventually apologize for that behavior in the debriefing and actually analyze what went wrong so it gets better the next time versus denigrating the people who might not have anything to do with that bad event.
Okay. Are you talking about more physical violence or verbal violence or both? What do you see more of, and what have you had to deal with?
Well, I mean, I think the 21st century physical violence is completely, unacceptable, and it's probably a criminal behavior at some point. So it's mostly verbal abuse, cynicism, degrading people, sometimes throwing instruments on the floor, yelling, screaming in the OR or in the ER. Those are the behaviors that affect the patient or the patient safety by affecting the way the team works.
Yep, I know exactly what you mean. I share openly with people how I was a bad leader myself, especially in the beginning of my career, and continue to work on myself. And there were times when I apologized to my staff for having been under pressure and saying things that I shouldn't have said. What are the steps? Let's talk about the 3 steps that you think can help organizations, help these physicians, and change the culture in the workplace.
Okay, so the basic requirement or the basic expectation is that all hospitals that are surveyed by the Joint Commission would have on the record, on the books, bylaws regarding this situation. Describe what the disruptive behavior is, describe what the expectation of a normal behavior is, and then ways to resolve those issues with the physicians who show this disruptive behavior. From my perspective, at the level of a clinical leadership, chairmanship, or a chief of service, you need to set up expectations. But before you do that, you want to educate your team about why disruptive behavior is bad for patient care, patient safety, satisfaction of the team that's working with you, and actually the expectation of the team from you as you are leading that team to care for extremely ill patients. So education is important. Expectations, like what's your expectation from your team? Is a occasional outburst as you're advocating for a patient okay? Probably okay, but this cannot just be repetitive. Can't be like you're advocating for your patient every other day. You can't be screaming at people for no reason.
Right.
And my expectation is literally to apologize, if even if this was a one in a while long, in a while outburst. I think uh, apologizing will just make the people around you feel that you appreciate their work and that you are open to suggestions to solve the issue that led to this outburst.
Mhm. And setting expectations, what kind of results have you seen by doing that? I love that. What kind of results before and after, by setting expectations, did you see in the organization? And then also, one last thing is, what if it didn't work? What do you if you have that one physician that continues? What do you do then?
So if it's a one-time deal, you just let it go, and sometimes maybe you can, in a informal way, mention that is that incident to that physician or to that surgeon. Hey, by the way, I heard this. I'm sorry this didn't go well, and thank you for apologizing to the team and made out for the confrontation. Sometimes you hear that actually that particular surgeon has frequent outbursts in the OR. And if this is the first time you've heard about it, then you just have what we call a cup of coffee meeting. Very informal. Hopefully, probably not in your office, but sometimes you have to with the work schedule that everyone has, and just have a friendly meeting. And I shared with you the story before. I just once heard 2 years into one of my jobs that the OR nurses dreaded Friday because that surgeon operates on Friday and is a very, very poor manners and very bad temper. And simply, I just gave that surgeon a call, invited him to my office in the evening after the work day. And I told him what I heard. And he was sort of surprised. Whether he was genuinely surprised or not, I can't tell. We had literally less than a 5-minute conversation. There was no pushback. Thank you very much. He walked away. And a Monday after, I got an email from the OR manager thanking me for that intervention because that surgeon's behavior changed dramatically just overnight.
Wow.
So sometimes it works,
Yeah,
and
sometimes
hopefully
it's
most
just a
of the time it
matter
works.
of awareness. We're not aware
Exactly.
of how.
Yeah. It's self-awareness. People just whether it's the cultural way, the upbringing, that how to relate to your subordinates, to other people, whether you think you're just being funny but you're really not being funny. It's just you just don't know how people are thinking. We
Right.
definitely presume that people do not come to work to have fights, to hurt their teammates, or to hurt patients. Everyone, we presume, has a good intention, but they just do it in a different ways.
I love the way you manage this, Dr. Cachecho, because what you're saying to us is, have a cup of coffee, have a conversation, find out what's going on with that physician. It's not just to put them aside and reprimand them and then tell them they're on probation or about to get fired. It's actually trying to really figure out what's going on with that person. Sometimes, people talk about how disruptive behavior can be a manifestation of something deeper that's going on with that particular physician, with burnout that's going on these days and being as high as 50 to 60%. It could be that the person's burned out. What do you think about that?
I agree with that. But as anything else in life, I think we have to treat our teammates or other, I'm going to call it significant others, in a professional way. Have to treat them with respect, whether you're under pressure or not. And I think some physicians might need some counseling.
Yep.
So there are processes, every hospital has processes to go through before you get into that counseling stage, which might be actually very difficult. I mean, I had the opportunity to be part of some of that in my past life. And to tell a surgeon that you need to be counseled, to have to see a psychiatrist or see another physician to lead you into better behavior is very, very difficult to do. And it takes a personal, level of, your personal relationship with that physician is completely now different, because you're trying to intervening into your literally private life, and they're, referring them to another healthcare professional to make them change their behavior. So it can be very touchy.
Right. So let's talk about some of the touchy stuff here. If you feel comfortable with it,
Sure.
can you give us an example of where you had some difficulty in using your standard ways to get that specific surgeon to change their behavior in the OR or wherever they were in the workplace? What kind of steps did you have to take, and what recommendations do you have for organizations or other physician leaders to deal with that?
Well, it's very important to have the support of your executive personnel in the hospital. You can't do that alone. You can't challenge, a physician's livelihood, future, licensing status, privileging in the hospital without having support from the administration. And then you just follow the bylaws by the book. You request meetings, and you can have witnesses for those meetings. And sometimes there are situations where that physician literally refuses to meet, refuses to answer your emails. Then you have to reach out to the chief medical officer, to the medical executive committee, the president of staff, and sometimes to the board of directors. You need to use all the administrative power that is supportive of your action to solve that issue. And if you have been a role model in your behavior, and the administrators believe that you're doing it for a good reason, not to take it on a specific physician, then they will support you and they will do everything possible to make that work. No one wants to get rid of surgeons or physicians for bad behavior. They just want them to change behavior. And one more thing, we can't change people's personalities. We only can change their behavior. So only with feedback, with expectations about the way they are accountable for their behavior, that will make them change. And it works. It has worked in my most extreme cases, when I reached out to CMO and the board members to support me in dealing with some of those physicians.
What kind of leader does it take to do what you do, Dr. Cachecho? Because not every physician leader has the skill to talk to a difficult physician where there's conflict. So, what skills have you had to develop within yourself to do what you do?
Well, it's a personal development. Actually, it's just learn from others, learn from people who spoke to me. I wasn't the greatest example of a good, non-disruptive physician when I was a younger surgeon, and I, just like yourself, I changed over time. So I looked at myself and see what things that made me change, and I used them with certain physicians that I had to deal with. And then you just have to be principled. Is a disruptive behavior acceptable, even this is the best surgeon in your medical center? If you accept it if you accept that behavior for that surgeon, are you going to accept it for a, uh, a different surgeon who might not be as famous as that surgeon? I think you have to treat people evenly. You have to have a transparent program, and your behavior has to be very clear and transparent to everyone, that no one is above that rule and everyone has to abide by that rule,
Yep.
including yourself.
Well, I love this conversation. Thanks so much. I think the key word is self awareness. You are someone I see as being very self aware, and where you were and where you are now, and that translates into helping others being self aware. of what they're doing, because we aren't. Most of our days are subconscious living, right? We do so many things habitually that
Yeah.
we don't realize that we're doing it sometimes. So thank you so much for this
Okay.
conversation.
My
Um,
pleasure.
how can people reach out to you if they have some more questions or want some of your expertise?
They can find me on LinkedIn, or my email address is available if you can make it available to them. And here it is. Please call me, connect with me, and we can have conversations.
Thank you so much. Thank you so much for being here, Dr. Cachecho, and sorry about the delay from last time. I,
Yeah.
I appreciate your resilience and your flexibility.
Yeah.
Again, my name is Dr. Elsie Coe. Please reach out to me at info@drelsiecoe.com if you have a story that can help physician leaders. I love to hear from you so we can make this known and make our healthcare system even better for all patients, for the whole community, for the organizations, and especially for our physicians. I have a website that I would like to put on there. If you want to learn about what we do at leadphysician.org, please look up there. And everyone have a great Sunday. Happy Super Bowl Sunday.
Happy Super Bowl.
Thank you. Take care.
Thank you. Bye.